Good morning, everybody. Thanks for joining us today for another great Grand Rounds presentation. Due to as everybody's aware of the surge of the Delta virus, we've had requested a little bit more of the updates we used to do in the past. And so we have a couple extra updates to let everybody know what's going on in regards to the numbers and so on. So we'll get right into that right now. We'll start with Dr. Ben Pinsky, who will update on what's going on with the variants. Dr. Pinsky, I'll turn it over to you.
Thanks, Errol. So I'll give a brief variant update. As everyone knows, the Delta variant has taken over our population. And remember, we screen for all of our positive samples with a mutation-specific PCR that looks for important mutations that are associated with these variants of interest and variants of concern. And Delta contains this L452R mutation. And I'll show the epidemiologic curve on the next slide. I just want to mention that we've also started seeing B1621. This is not yet a variant of concern or interest in the United States, does not yet have a WHO name, so no Greek letters yet, but it has been reported in the media as part of a surge in Florida. And this contains two other important mutations, E484K and N501Y, that are also found in beta and gamma. So here's our curve of cases. You can see here is when Delta was introduced at the beginning of May. And in yellow is basically L452R mutation that corresponds with Delta. This is when we reopened California, and you can see the subsequent increase in number of cases and the really takeover of the Delta variant, which you can see on the right side, accounting for approximately 90% or so of our cases, which is consistent with what's being seen in the rest of the United States. Our 7-day positivity rate overall is just under 4%. This is up 1% since last week's report. So here, this is the variant update. I'm happy to take any additional questions in the chat. Thank you.
Thanks so much, Dr. Pinsky. For next week, our upcoming Grand Rounds is going to be led by Drs. Crow and our own Chief Resident, Dr. Blessing. They're going to be kicking off Breastfeeding Month, National Breastfeeding Month, with the actual title we have here signed up. It's Got Human Milk, Optimizing Lactation Culture and Support at Stanford in celebration of National Breastfeeding Month. The week after that, we have a number of doctors joining us, including our own Dr. Pinsky. We'll be talking more about the SARS-CoV-2 variants as well. So we'll have a mix in the future of pandemic-related and non-pandemic-related topics as we move along, but we'll continue to keep you updated every Grand Rounds. So this week, speaking of, we have a really great topic. We have two great doctors with us, Dr. Mayuri Chandran and Kevin Schulman. We're really excited to have Dr. Chandran with us as one of our own residents from our internal medicine residency program. She she graduated from the University of Chicago with a biological science degree in 2014. After that, she went to the University of Michigan Medical School, where she finished school there in 2019 and came and joined us at the Stanford Internal Medicine Residency Program in 2019. I want to mention that Dr. Chandran, going along the topic of what our presentation will be today, you could tell looking at her CV that she has a history and a passion for a specific type of topic that involves really health disparities. For example, she had a presentation and article that was entitled The Protective Wall of Human Community, the Social Connection in Substance Abuse Recovery. Another one here is being from the Michigan area, a prescription for water, educating doctors on America's growing water crisis. She conducted independent research of water insecurity through audio interviews and interviewed people affected by home water shutoffs, health experts, public officials, and community organizers to produce an audio commentary, essentially a podcast about the health consequences of water shutoffs. She's been doing some really excellent work here. She's going to be sharing with us. And she's going to be presenting along with Dr. Kevin Schulman. I think if you don't know Dr. Schulman, but have been attending these Grand Rounds the past year, you probably know him pretty well because he's been a key member of a lot of things that we do in our community. Dr. Mahoney just mentioned them, and as part of town halls, he's been a big part of our grand rounds, really structured this whole past year and a half that I've been part of the grand rounds in regards to the pandemic. Dr. Schulman is professor of medicine. He's the associate chair for business development and strategy department of medicine. He's the director of industry partnerships and education for the Clinical Excellence Research Center, or CERC. By courtesy, he's also professor of economics at Stanford's Graduate Business School. Dr. Sherman's research interests includes organizational innovation in healthcare, healthcare policy, and health economics. With over 300 articles, original articles, hundreds of reviews and commentaries, countless case studies, book chapters, he has a broad impact on health policy. He was a professor, before he came to us, professor of medicine at Duke University. He directed the health sector management program at Duke's Fuqua School of Business for dozens of years. He created and directed the Duke University's Masters of Management Clinical Informatics program, which he also started here at Stanford, that started this past year as well, a master's program here. And we're really lucky to have him with us again today. So Dr. Schulman, thanks as well for being part of this. Dr. Chandran, thank you very much for joining us today as well. And I will turn it over to you to start sharing your slides.
Great. Well, thank you so much, Errol, and thanks for that gracious introduction. Mayuri came to me about 6 months ago and told me about her interest in sociology. And we began working together on this talk to try and explain a lot of the national policy discussions that are going on around racial disparities in healthcare and in health, and to talk about how the conversation has actually switched during the current administration to less of a focus on healthcare and more of a focus on health. So I don't want to take any more of her time. Mayuri, thanks so much for your hard work to pull together this talk.
Thank you, Dr. Schulman. I've really been looking forward to having this conversation, and thank you all for taking the time to listen. I'll start with a brief statement on my positionality. As an American citizen of Indian background, I do not have the lived experience of some of the populations and factors that we'll be talking about today. I think it's important in academia to point these things out when we talk about racial disparities. So with that, let's jump right in. So this is what I've been seeing when I've opened my news apps every morning. Racial health disparities are making mainstream news in a way that I've never seen before. The trends that all of us have seen on the ground in COVID wards have attracted national attention. I'd like to highlight a headline from the New York Times just last week. Life expectancy plunged in 2020 for Black and Latino populations. Between 2019 and 2020, the Latino population had a drop in life expectancy of 3 years. The Black population had a drop of life expectancy of 2.9 years. Both of these are significantly higher than the drop in the white population of 1.2 years. And these are the statistics behind all of those headlines. This was a study of 50 million active EPIC patients, so a reasonable proportion of our population. The disproportionate burden of disease in Black and Latino populations is obvious in this graph. Black and Latino populations had a 3.3 times and 4.3 times rate of COVID hospitalization respectively, and a 2.4 times rate of COVID-associated death. We're at a unique moment in which these statistics are actually being widely shared and widely acknowledged. We're gaining a renewed national consciousness of racial justice in the Black Lives Matter movement. The statistics we just saw and those to come are disturbing, no doubt about that. This is a difficult conversation to have, but this might be a unique opportunity to understand and make progress on racial health equity. Here are the questions that I'd like to ask today. Number one, what is the impact of healthcare on health outcomes? Conversely, what are the impacts of other factors, socioeconomic factors on health outcomes? And then knowing this, how can we have a significant and meaningful impact on health in our country? Our training as physicians focuses on healthcare. And our institution shown here is one of the best examples of what cutting edge healthcare can look like. Our approach to health disparities in the past has focused on getting this quality of healthcare for everybody. But foundational studies in the field have shown that quality of healthcare delivery differs significantly by race. In this study by Dr. Schulman in 1999, different actors were given the same script for cardiac chest pain. Physicians were then asked to give a recommendation for cardiac catheterization. Given the exact same clinical presentation, Black women were less likely to be referred for cardiac catheterization than white men. This was one of the first studies to identify subconscious bias from providers as a factor in care disparities. This field is expanding and evolving. On the right, we have a graph of publications on this topic, and we can see a significant increase in interest over time. So there have been a lot of researchers investigating disparities in healthcare, but there's a parallel body of literature developing looking at the relative contribution of medical care to health outcomes. This was a study by Bob Kaplan and Arnold Milstein, both here at Stanford, which suggests that medical care has a relatively modest impact on health outcomes. Here, we're not even pushing 20% of an impact. The Robert Wood Johnson Foundation created a comprehensive framework, which is consistent with the literature shown before. This also suggests a very modest impact of clinical care on health outcomes, just 20%. We might have a more significant impact on health if we consider some broader social factors. Understanding this diagram is what's motivated me to pursue a PhD in sociology after residency. And my goal is to strengthen the connection between medicine and social science in order to have a broad impact on health. Before we can dive into the relative impacts of socioeconomic factors on health, it's important to start with some historical context. Each of the factors on the right is impacted by structural racism. This is a term that's becoming more and more present in the national dialogue, so it's one that's important to define. Structural racism is defined as racism embedded in long-standing social policy. Structural racism has its roots in slavery and in the Jim Crow era. Jim Crow laws enforced racial segregation in just about every avenue of life. This includes education, healthcare, transportation. These laws were primarily from the late 1800s, but lasted all the way through the mid-1900s. Both of these two pictures are from North Carolina, which, like other southern states, had a really heavy burden of Jim Crow laws. The picture on the left shows a segregated bus station, and the one on the right shows a segregated hospital. What's less apparent from these black and white photos is that they happened within recent memory. People are alive today who lived through both of these things. In North Carolina, public schools were not required to be integrated until the 1970s. The legacy of Jim Crow is persisting in new forms. We'll examine redlining and mass incarceration. Like structural racism, redlining is a term that's gaining national consciousness, so it's important to review its history here. After the Great Depression, the US government wanted to evaluate the riskiness of home mortgages. It created an entity called the Homeowners Loan Corporation, or HOLC, which graded neighborhoods into 4 categories, largely based on racial makeup. Minority neighborhoods were rated as high risk in red. They literally created red lines as seen in the map of our area. So this is San Francisco and Oakland. So California and the Bay Area were not immune to this type of segregation either. These neighborhoods were ineligible for federal home loans. This effectively excluded people of color from home ownership. This is not a historical issue. redlining has real implications for health today. Formerly redlined areas have lower life expectancy persisting into the 2010s and now. On the left, we've got a chart of those historic redlining maps from the 1930s. On the right, we've got a map of life expectancy in our area. The areas in the lightest purple have the lowest levels of life expectancy. And we can see that this corresponds almost exactly to that historic map. Another recent study has shown that formerly redlined areas have a higher rate of comorbidities, which increase the risk of severity with COVID-19. These are risk factors like diabetes, hypertension, asthma. Another legacy of Jim Crow is mass incarceration. The US is truly an outlier in this domain. The US incarcerates more of its own citizens than any other comparable country. As we can see in this graph, the rate of incarceration has been steadily rising since the 1970s. And who is the US actually incarcerating? It's primarily people of color, and the trend is worsening. We can see that for men born in the 1940s, there is already a significant difference in the risk of imprisonment between Black and white people. This difference is amplified by low educational attainment. We can see that the difference is becoming more pronounced over time. A recent study showed that Black men have a 28% lifetime risk of imprisonment. That's greater than 1 in 4 chances of serving time in prison. Mass incarceration not only impacts those who are incarcerated, but impacts the health of whole communities. Currently incarcerated people have higher rates of infectious disease, sexually transmitted infections, hepatitis, HIV, chronic medical conditions, substance use disorders, and mental health conditions. Formerly incarcerated people face additional social burdens. They earn about 30% less income than similar never incarcerated peers. These effects have cascading impacts on the next generation. Children whose parents have been incarcerated report poorer physical and mental health. These changes persist through adolescence and into adulthood. Health differences have been underlined by this current pandemic. We can see that the rate of COVID infection in the prison population dramatically outpaces that of the general US population. By June 2020, the COVID case rate for prisoners was 5.5 times higher than that of the general population. The death rate was higher too, which is remarkable because the prison population is younger. The disproportionate burden of these COVID cases will likely have cascading consequences on these communities. Now that we've reviewed some historical context, I'd like to move to the specific impacts of socioeconomic factors on health, starting with economic factors. The clear message from this section is that more income means more health. This was a really remarkable study by Raj Chetty, who used to be here at Stanford. This was based on 1.4 billion person-year observations. We can see clearly that the age of expected death increases steadily as income increases for both men and women. The gap in life expectancy between the richest 1% and the poorest 1% is 14.6 years. This impact of income is shocking. A 14-year life expectancy difference really puts our medical interventions into context. Higher income is associated with greater longevity throughout the income distribution. There is no threshold at which more income does not provide an advantage. People talk about a happiness threshold at about $70,000 in which more income doesn't produce more happiness. That is not the case for life expectancy. Knowing that income is associated with health it's important to know how income is distributed across the US population. The answer is unequally and worsening. The graph on the left shows the Gini index. This is a statistical measure of income dispersion. A high Gini index means more population inequality. We can see that income inequality has been steadily rising since the 1970s. This inequality in earned income translates to an inequality in accumulated money or wealth. In the late 1980s, the top 10% already held a disproportionate share of wealth at about 67%. In 2016, it's only worsening. The top 10% holds about 77% of wealth. The bottom 50% held just 3% in 1989. Now, they hold about 1% of this nation's wealth. In a survey by the Federal Reserve, 37% of Americans said that they would have difficulty coming up with $400 in an emergency. These trends can be mapped on a racial axis. The blue line represents the median wealth of white families, and the yellow line shows the median wealth of Black families. In 2016, a typical white family had 10 times the wealth of a typical Black family. One of the major ways that families pass down wealth is through home ownership. So this is another lasting impact of redlining. The wealth gap translates to a stark difference in population poverty rates. Poverty rates are much higher in Black and Latino populations. They increased disproportionately after the 2008 financial crisis, and they've been decreasing in the economic expansion over the last 10 years. But we don't know what the economic impacts of COVID will be. The pandemic has had vastly different impacts on different segments of society. High wage earners have similar rates of employment or even slightly higher from pre-pandemic levels. Lower wage earners, in which minority communities are disproportionately represented, have employment rates that are about 21% lower than pre-pandemic levels. There might be a balancing effect from federal spending programs, but these programs are timed to end. We'll talk next about the impact of social factors on health outcomes. We talked earlier about the history of discrimination. Current discrimination also has an impact on physical health. This was a study by Sherman James, who was a visiting scholar here at Stanford. In this study, people with the highest quartile of self-rated discrimination had a greater prevalence of hypertension. The national epidemic of gun violence is felt unequally. The burden of firearm homicide is disproportionately concentrated in young men of color. Education is another social factor that is deeply connected with health. This study, the Carolina Abecedarian Project, was really remarkable. It's one of the very few randomized controlled trials in this space. James Heckman contributed to this study, and he actually won the Nobel Prize for doing this type of work. In this project, children were randomized to receive a generalized early childhood education program, basically preschool, or randomized to receive no intervention for the first 5 years of life. Children who were randomized to receive the education program had improved cardiovascular and metabolic health. These health benefits persisted through adolescence and into adulthood, up to their mid-30s in follow-up studies. Increased education later in life is also associated with increased longevity. The difference in life expectancy for a man with no high school diploma and a man with a graduate degree is 16 years. The difference in life expectancy for a man with no high school diploma and one with a high school diploma is 7 years. There are differences in high school diploma attainment by race. In 2017, 94% of the white population had a high school diploma, while only 71% of the Latino population did. We'll talk next about health behaviors. I think the important point to make here is that health behaviors are often thought of as personal choices. I'd like to demonstrate that environmental influences actually have a huge impact on what choices people are free to make. We're starting to think about differences in access to healthy foods, but the problem is actually more fundamental. There's a significant difference in access to adequate food at all. People of color disproportionately experience food insecurity, which the USDA defines as a lack of consistent access to enough food for a healthy, active life. In 2018, greater than 20% of Black households lacked adequate access to food. These patterns, again, follow historic redlining maps. The map on the left shows the historic redlining scores from the 1930s. The map on the right is an interactive map from the USDA showing areas of low food access currently. Formerly redlined areas correspond to areas of low food access now. These low income areas have lower access to vehicles and historic disinvestment in public transport, which makes low food access even more impactful. There are differences in tobacco advertising. There are up to 10 times more ads for tobacco in Black neighborhoods than in other neighborhoods. The type of advertising differs as well. There's increased targeting for menthol cigarettes, which are easier to smoke and harder to quit than other cigarettes. 85% of Black smokers use menthol cigarettes. This is a rate that's about 3 times higher than that of white smokers. The last factor on our agenda is physical environment. We can see here that redlining has reared its head again in the form of reduced tree canopy cover. Formerly redlined areas, these are areas with high minority populations, have about 23% tree canopy cover today. Areas that were deemed to be the least risky investments, areas with higher white populations, have double the amount of tree canopy. Significant differences in pollution exposure as well. This was a study published in the Proceedings of the National Academy of Sciences 2 years ago. The chart on the left shows that minority populations are exposed to more pollution. The authors actually took this one step farther and calculated exposure relative to production of pollutants in order to create a pollution inequity index. On average, the white population experiences a pollution advantage in which they experience 17% less air pollution than is caused by their consumption. Black and Latino populations bear a pollution burden of about 50 to 60% excess exposure than is caused by their consumption. This brings us to the issue that I've had some personal research experience with, water insecurity. The necessity of water for health has become abundantly clear during this pandemic. We need clean water to wash our hands and prevent the spread of disease. But access to clean, safe water is becoming increasingly tenuous for low-income Americans. As a medical student in Michigan, I spent several months living and working in Detroit. This city is unique in several ways and has had pretty seismic economic and demographic shifts over the last 100 years. In 1940, the city was 90% white. It's currently 82% Black. It used to be the epicenter of a booming auto industry. Currently, 1 in 3 Detroit residents lives in poverty. My perspective here was limited to that of a temporary observer. I did not live through these changes, nor did I personally experience their after effects. But this observer position gave me a window into the ways that social factors can powerfully impact health. Since 2014, over 100,000 people in Detroit have had their water shut off due to inability to pay their water bills. I interviewed people affected by water shutoffs, health experts, community organizers, and politicians in order to make the podcast that's shown on the right, called A Prescription for Water. This podcast is available on the podcast app, and we'll be sending out a link to it as well. So here is what water shutoffs actually looked like in Detroit. Areas in dark red had a water shutoff rate of greater than 15%. This means that 15% of people at some point needed to use gallon jugs of water to wash their hands, cook their food, clean their houses, and flush their toilets. I talked to people who dug pit toilets in their backyards because they didn't have running water. In America, this crisis has actually gained international attention. The UN sent a special reporter on the human right to water to Detroit. She said it was contrary to human rights to disconnect water from people who simply do not have the means to pay. Unfortunately, this crisis is not localized just to Detroit. Water and sewer prices are dramatically outpacing the cost of other utilities in this country. So water insecurity might become common in other urban and rural areas. This brings us to the most important question. How can we operationalize this knowledge to have a meaningful impact on health outcomes? What's bringing me hope is that this conversation is expanding outside of academia and outside of community organizing. Our national leaders are changing the conversation and taking an evidence-based approach to improving health in a broad sense. I'd like to focus in on a quote by Don Berwick, who's the former administrator of Medicare and Medicaid. He said that no scientific doubt exists that mostly circumstances outside of healthcare nurture or impair health. We're seeing leadership in this space at the federal level. This is a breakdown of the spending proposed in the Biden administration's 2 sweeping legislative proposals. We can see that each of these proposals target the social domains that we talked about earlier. This may have a huge impact on health, even though it's not explicitly health legislation. The theoretical health benefit and social spending is supported in practice. This is a study by Betsy Bradley. She founded the Yale Global Health Institute and is currently the president of Vassar College. It showed that states with higher ratios of social to health spending actually had better health outcomes. This means that social spending potentially has a more significant impact on health than healthcare spending. Academic medical centers have a real role to play outside of our immediate focus on healthcare delivery. Rush University in Chicago is leading the charge here. They have taken an effort to go beyond their mission of providing healthcare and instead investing in the economic vitality of their local community, the West Side of Chicago. They've made it a priority to hire locally, buy locally, and invest locally. And we at Stanford are taking a step in this direction as well. This is Stanford Hospital's Community Benefits Summary, which we present annually as part of our nonprofit status. We've seen a massive increase, a 79% increase in our community investment over the last fiscal year. COVID has changed our response. and has caused us to direct our investments more broadly towards community health. Maintaining and building upon this change has huge potential for health improvement. In summary, we looked at the evolution of health disparities research. We found that the impact of healthcare on health outcomes is relatively modest, and that broader social factors have significant contributions to health. It's an important question for Stanford whether we'll continue to focus our disparities efforts on healthcare or on health more broadly. Finally, to my co-residents, when we get lectures like this, we're often encouraged to be better informed or to try harder on behalf of our patients. This feels impossible when we feel like we're already giving 110%. We in the healthcare system are called upon to address society's failings, and our tools for doing so are all too often imperfect. Know that your frustration is shared, progress is slow, but you do have a powerful voice to move the needle in this conversation. Thank you.
Dr. Chandran, that was excellent. That was an amazingly, I mean, I can't believe how much information you put in the short time we gave you to present, and very enlightening talk. I just want to mention to everybody, feel free to put in any questions if you have any questions for Dr. Chandran. For our panelists up here as well, if you have any comments or questions, feel free to chime in as well. I have a question for you, Dr. Schulman. Any comments before I potentially ask mine if we have time for it?
No, go ahead, Errol.
Dr. Chandra, you talked about redlining. It's something that I just was learning about in the last couple of weeks. It's been getting a little more attention. I guess I watched a documentary on it about a week ago. Living in the Bay Area, I think anybody who's searching for a house for a few years, and I've seen the ability of people to gain wealth from housing. And that, as I learned more, it's become more financially just aware of things. Housing has been a huge aspect of how people in our country gain wealth. And this fact of redlining has had this impact of basically different aspects of our culture. African Americans, for example, how they had the lack of opportunity to get housing and get loans to buy housing, to own housing, so they can appreciate their equity, that they can go and gain wealth. My question to you, so thank you for bringing attention to this. It sounds like you did a great job of talking about all the different aspects of what has gone into creating this inequity in wealth. Does it sound like, to your knowledge, that it's really this housing aspect that's probably the primary driver of the inequity of wealth? Obviously, it's a big comment. And the bigger question, which I know no one can really answer, but that this documentary I watched recently really tried to go into, what can we do now to even that playing field? That's the $1 million question, which I don't know anybody has an answer to, but someone with the background you've had in this now, what do you think we need to do to help reverse some of this? I don't think it can be fully reversed.
These are great questions. I wish I had an easy answer. Your question about the relative contribution of redlining to the wealth gap is a great one. And I'd love to actually get some data for you and send it out in an email afterwards. I know that the contribution is significant just given the history, but I don't know. There's probably many more factors that play into this. In terms of what to do moving forward, maybe I'll toss it over to Dr. Schulman.
Well, thanks so much. Thanks, Errol. I think the national conversation really is changing now to try and go back and look at these basic causal factors. I mean, we started, Mayuri kind of talked about this term structural racism that is part of the national discussion. And how do you reconstruct 100 years now or more of these inequities in terms of people's ability to accumulate wealth? And what can you do about that? So I think that's a huge part of the national discussion. And I agree, there's not a simple answer to that. So I'll just leave it there. I do think it's important for us to realize the health aspects of this, and the confounding influences of health, of wealth on health.
Thanks, Dr. Schulman. That's really helpful. I think, Dr. Chandran, you most of all talk about how the impact of these populations are more than just what we do at much of what we provide in medical care. It's so much deeper than that. And we know this, but to see this data, to understand a whole nother level is so valuable. Dr. Schulman, any other comments or questions from you?
No, I think, what we wanted to try and do here is present this, you see this huge change in rhetoric at a national level in all the public discussions about inequalities. We've seen lots of these data, especially the income inequality data, which is really staggering what people's expectations are for dispersion of income across the country and dispersion of wealth, and what the realities are just really don't match up, and don't match up to what Americans think the ideal would be. So we wanted to try and bring some of those data forward, try to help inform ourselves about the national discussion. And then I think at the end of the day, we left this with, our discussion here at Stanford. We've been in a lot of department discussions and school discussions about health inequalities and how do we respond to health inequalities. And I think it's a really important question for us to think about how much healthcare and healthcare delivery and healthcare services are a solution to some of these questions, and how much broader social advocacy or community investment opportunities that we could advocate for as a community, can make a contribution. I guess we have a couple more questions coming in.
Yeah, one question here from Dr. Poon. Government money spent in social services high. What has been the effect of that? Any comments from that perspective?
We had some data that from Betsy Bradley again about community social spending that Mayuri presented, that basically social investments do have dividends in terms of health outcomes, as you expect. Things like food, education, transportation assistance are all going to have an impact. The other thing with the stimulus bills over the last couple of years, with the tremendous amount of money that was pushed out from the federal government, a lot of that was to go into safety net, and actually we'll have to see what the impacts, safety net programs, we'll have to see what the impacts of those are over time in terms of impacts on health and wealth.
Dr. Dunn, I see you up here. Did you have a question you wanted to ask?
Sure. First, I want to say thank you so much, Mayuri, for this wonderful presentation. It was informative and it's a very important topic. I mean, I think honestly at Stanford here and in healthcare in general, we really just can't rest and be satisfied with all that we're doing until there's health equity. And so I think this is a very important piece of our puzzle, educating folks. I think that medical schools and training programs are doing a lot better in educating folks about structural racism, and have really, taken the charge in this moment where our conversation has changed. The nature of the conversation about racism in particular has changed. Do you have any ideas about how we might really continue to educate our faculty about this? Some of the people that who have been around for a very long time, and were not educated in the way that the medical students are being educated now.
That's a great question. I think avenues like this are a great place to start, right? I mean, this brings together all of the levels of medical training, and you're right, because my medical education had more of this kind of component to it. It's more a part of my understanding when I practice medicine, and so I think that we people, medical students and residents, have some role to play even on rounds in terms of educating our faculty members and pointing things out.
Thank you.
Thanks for that great question, Dr. Dunn. Dr. Chandran, Dr. Berry asks, she says first, Mary, fabulous talk. As you come from Michigan home to Flint, can you talk about widespread geographic contamination of water that has occurred due to poor infrastructure?
Yeah, so just a little bit of a clarification too. I'm from Chicago, but temporarily was in Michigan, but the levels of water insecurity and the number of kind of compounding issues in Michigan are so unique. What a lot of people don't know is that this Detroit issue is actually completely separate from that of the Flint issue. I'll send out a little bit more information on Flint as well, because it's an important one. That was primarily an infrastructure and investment issue as well. When the city of Flint switched the pipes that it used, it switched its water source, it switched to pipes that were more likely to leach lead into the system, and that resulted in a number of children getting irreversible lead poisoning.
Dr. Chandran, really interesting question here. Rob asks, have you seen much study of the effects of healthcare costs and medical bankruptcy on health inequity?
I feel like this is a great Dr. Schulman answer.
Yeah, no, I think the medical bankruptcy, balance billing, some of that, obviously a lot of that burden disproportionately falls on these populations that might have been uninsured, might be in between jobs. The good news is there's new national legislation, the No Surprises Act, that actually is going to halt at least surprise medical bills. But there are all constantly stories about, and actually during COVID, we weren't, hospitals were precluded from going after balance bills from people during the pandemic. And yet, even despite national requirements that they didn't, hospitals continue to pursue bills. So I think this is obviously exacerbates all this, plus all of these practices, surprise medical bills and claims, make it so that people don't want to come in because they're really afraid financially of what the implications might be from seeking care.
Another question here, Dr. Ariagno, does structural racism also correlate with access to healthcare and preventative measures?
Mayuri talked a little bit about redlining and metabolic syndrome. We've talked a little bit about Sherman James's work in perceived discrimination and hypertension. So there definitely are health impacts of all these decisions. Plus, we talked a little bit about availability of food and food choices, of healthy foods, of not processed foods that really differ across these different areas. So that's at least some of the ways in which the underlying mechanisms of this might be continuing to work today outside of other, education or income.
Great. Dr. Leibowitz asks, this is commenting a little bit on with Dr. Berry. So isn't bringing water to Great Lakes like bringing coals to Newcastle? I thought they could pipeline clean water to the rest of us. Surely the water problem in Detroit isn't due to infrastructure. It's due to infrastructure, not water availability. Is my understanding wrong?
So yeah, the issue with water is due to infrastructure and affordability. The Detroit water and sewer system was built for the population that existed in the 1950s. So that's much denser and much more wealthy than the population that exists now. Currently, there's been so much disinvestment in maintenance of Detroit's water infrastructure that a lot of this piping is damaged, it's leaking water, and it's not going to homes that are occupied. The primary payer base of the Detroit water and sewer system has left for the suburbs. So now we're left with a smaller and less wealthy payer base. And so in order to support those infrastructure investments, they've had to hike up the prices, and then people can't afford those prices.
Thanks, Dr. Chandran. I want to mention one last comment here, Samantha Moraine, just acknowledging better access to affordable housing and noting what's going on just right here in East Palo Alto, people being forced away. So thanks for that comment, Samantha. Dr. Harrington, I want to turn it over to you before we close it up.
Yeah, so I just want to make a couple of comments. First off, Mayuri, that was absolutely outstanding. And you made us all proud in the Department of Medicine. And I will say, I could have said that would have been absolutely outstanding if a full professor of medicine gave that talk. And the amount of work you put into it, your understanding of the topic, kudos to you. And I want to thank Kevin, because these kind of things happen with the obvious tight mentorship and partnership that the two of you have had. So congratulations, Kevin. It's what we want to see from our faculty mentors. And so thanks to both of you. I did want to make a broader comment for the audience before I turn it back to Errol. After much discussion throughout the pandemic about how intertwined we in the Department of Medicine need to be with our surrounding community. And that was clear throughout the pandemic. It was clear in the hospital. It was clear in the testing facilities, the vaccination facilities, that we are really looking to expand our tripartite mission to a 4-part mission that will also include community engagement. There is an application process underway for an associate chair of community engagement, and I would invite people to reach out to Eldrin Lewis, our chief of cardiology, who's chairing that committee if you're interested in applying. This is for members of our current faculty. So thank you, Mayuri, for bringing up a really timely and important set of issues. Thank you, Kevin, for your mentorship. And I'll give it back to you, Errol, to give people the update again for next week.
Great. Thanks, Dr. Harrington. I just want to also mention Dr. Chandran did mention a quote by Dr. Berwick, who was actually scheduled to present with us in October. Thanks to Dr. Schulman for connecting us in the first place. So thank you again, Dr. Chandran, for an amazing, enlightening presentation today. Dr. Schulman as well, thanks for being with us. Thanks again for our presenters for being part of this. Please keep us updated on what we can do to update you all. And hopefully we'll see many of you at the town hall today at 5 o'clock. Thanks so much, everybody. Have a great day.